Good afternoon, everyone. I hope you're all well. My name is Hugh Constant. I am a Practice Development Manager here at the Social Care Institute for Excellence. Welcome to the third in a series of webinars that we at SCIE are running on behalf of the Better Care Fund and the Better Care Support Team. Today's webinar is on the subject of intermediate care. And I'm delighted to welcome Jane Townson, who is the Chief Executive of Somerset Care, who will be talking about the links that they've developed with a hospital in Yeovil. I was fortunate enough to hear Jane talk about this at a national workshop that we ran in the autumn, so I know that you're going to find the next hour interesting and engaging with lots of good ideas about how to develop intermediate care services. You will see on your screens, hopefully, a chat box in the middle of the screen. It would be fab if you could use that to ask any questions that you have for Jane, any sort of issues of clarification, anything that you want to raise. I will be keeping an eye on the box, and at the end of Jane's presentation, I will ask her the questions that you've been putting forward in the chat box. Okay. So yeah, I think that's it from me. I will now hand you over to Jane. Okay.
Good afternoon, everyone. Hope you can hear me well enough. I'm going to be talking, as Hugh said, about a collaboration that we established with Yeovil District Hospital in October 2015, and it's still going. I'm going to start by giving a little bit of introduction to Somerset Care, so you know what kind of organisation we are. Yeovil District Hospital is a district general hospital. It's got about 350 beds and an accident and emergency department and all of the normal things that you'd expect in a hospital. Like everybody, it's been struggling with its patient flow and having beds available, particularly last winter, which was very difficult for all of us down in Somerset. So I'm going to start by just giving you a little bit of background to Somerset Care. So we formed in 1991 when Somerset County Council decided to outsource provision of adult social care. And we started off just in Somerset with care homes and the home care services that Somerset County Council used to provide themselves. And then over time we've expanded across southern England, as you can see in the map. So we're in Surrey, Hampshire, Isle of Wight, Wiltshire, Dorset, Somerset, Devon, Cornwall, Bath and North East Somerset as well. We're a group of companies. Our care companies are in Somerset Care Limited. We've got a company which manages our housing with care facilities, and we've got a wholly owned subsidiary training company as well called Acacia Training and Development. In addition, we formed a joint venture with McCarthy and Stone, who are the country's leading provider of retirement living, and they wanted a care partner and teamed up with us. So we manage the care into their assisted living establishments. So altogether we cover very low health and social care needs to very high health and social care needs, from people staying put in their own homes with home care through various forms of care into specialised housing, either retirement living properties or supported living for people with learning disabilities and physical disabilities, through to care homes which specialise in dementia care, frailty, end-of-life care, and, as you'll hear in a minute, intermediate care as well. So they're just a few stats. I won't go into them in detail, but they're there for you to look at. So we've got about 3,600 employees. Our turnover this year is about 68 million. We do home care. We were doing a lot more than we are now, but we've had to hand back quite a number of our local authority funded home care contracts because of financial unviability. In contrast, our housing with care work is expanding, and we have now got 70 developments open nationally with McCarthy and Stone, from Aberdeen to the Isle of Wight, from Cardiff to Suffolk. Supported living for people with disabilities and complex care needs, mainly in Somerset and Wiltshire, but we're involved in a lot of transition work with other local authorities, so talking to people like South Gloucestershire at the moment. And our care homes, we have 28 altogether, 1,531 beds, most of them in Somerset, one on the Isle of Wight, and we have about 40% of our income from local authorities and 60% from self-funders in the care home world. So just a little picture to show you what our assisted living developments are like with McCarthy and Stone, and a map showing you where they are all over the place. And by the end of August 2020, we're going to have 126, so another sort of 60 or so being opened between now and August 2020. And that's all CQC registered domiciliary care. This is one of our care homes, the newest one that we've opened, and we're very into technology in Somerset Care. We've actually had digital care records for 22 years in our care homes. We're just rolling out a mobile digital app for home care delivery management, but 80% of the care sector is still using paper records. We've also got electronic medicines management system that we've had in place for 8 years. And this home has been fitted with acoustic monitoring as well, which enables us to leave people who are asleep and focus our attention on people who are awake at night, which has enabled our residents to get better sleep. And other people that are using this technology have reported a reduction in falls of between 30 and 50% just from people sleeping better at night. Our mission is to enhance quality of life and promote independence of older and disabled people. And our focus on promoting independence is what's led us very much to focus on reablement. We do a lot of reablement work in home care, and we wanted to develop a service promoting independence, reabling people and getting them back home within our care homes as well. And we're very aware that in the social care sector, there is much less of an evidence base for practice than there is in say, health. And so everything we try to do, we want to have data to evidence it so that we can demonstrate improvements in outcomes, improvements in quality of life, improvements in independence, and very much research-minded, focusing on listening to our customers and doing what they want. Quality-wise, Lehman Buisson published league tables of compliance with CQC standards. We're currently third or second, depending on how you look at it, in residential care, with 95% compliance with CQC standards. We've got 3 services rated outstanding by CQC, a service which supports people with physical disabilities, and 2 of our homes which specialise in dementia care. In home care and supported living, we have 100% compliance with CQC standards, and that puts us at the top of the league table nationally, sort of jointly with various other organisations that have also achieved 100%. So I'm talking now about our collaboration with Yeovil, which is the main reason for the webinar. So I don't need to tell everybody about delayed transfers of care. Everybody in the health and care system is very aware of the impact that they've had. As you can see from the data, there has been an improvement since last year, and that's because many people in the country, many areas in the country are adopting services like Home First and working together more effectively with partners in care too. The headlines, of course, referring to our hospitals like third world countries, war zones, catastrophes, and this winter was particularly bad. So I mentioned that Yeovil has quite a lot of pressures on it, made worse last year by the closure of a walk-in centre in Yeovil, so that meant more people being diverted to A&E. So the goals of this collaboration initially and still are to improve patient flow at Yeovil District Hospital, reduce unnecessary length of stay, from the hospital's point of view, but more importantly from the individual people's point of view, because we know that staying in hospital too long when you don't need medical care can cause harm, and in particular reduce function and in the end cost more, because people then need more support when they come out. So enable appropriate reablement, maximise clinical outcomes for people and social and wellbeing outcomes, and ultimately to reduce the cost of ongoing care. So here's a picture of the care home that this happens in, and what originally happened was that we had approached Musgrove Park Hospital in Taunton about the idea of doing a reablement service with them, and we got in one of our nursing homes in Taunton, we got quite a long way down developing the concept of the project, working up a business case, working up what staffing levels we need and so on. And then unfortunately Musgrove Park, their financial position worsened, Monitor came down on them, and so they pulled the plug on that collaboration. Meanwhile, Yeovil had heard that we were in discussions with Musgrove, and they approached us and said, you know, we're really interested in doing something similar, would you be willing to collaborate with us? Now at the time we were halfway through building the care home that you can see in these pictures. So we started talking to Yeovil in the sort of spring, summer of 2015, and we opened this care home at the end of September 2015. It was like the 28th of September or something, and around about the October or November we started our collaboration with them. But it's a purpose-built nursing home, and what Yeovil decided to do, we went to the local authority and to the clinical commissioning group to ask for funds, and they both declined. So the CEO of Yeovil Hospital, then Paul Mears, said, well, I'll use some of our winter pressure money to block purchase the top floor of your nursing home, which has got 18 beds. So we were kind of being a bit rebellious, and we just did a provider to provider deal, just to establish proof of concept. So, the way we set it up was that the entire floor of our nursing home is used for this service. Our nurses and our carers work alongside Yeovil Hospital's therapy team, so they're occupational physiotherapy specialists and their rehab team. And the Yeovil team works on the floor of our nursing home from 8 o'clock in the morning till 8 o'clock at night, 7 days a week. And the physios and OTs rotate between the hospital and our service, and that's proved to be very helpful, because you avoid a situation where the hospital-based physios and occupational therapists are just sort of, you know, getting rid of people that they don't want for to be a problem to somebody else, because they rotate through. They know that they will also have to be working with people, so that's made, you know, a very good system. The therapists control the flow of patients from Yeovil Hospital to us, and also are very involved in the discharge from us onwards. Now, there are criteria for admission, and these have changed a little bit over time, mainly when the Home First service started, but essentially the things which have stayed constant are: there has to be documented confirmation by consultant of medically fit for discharge status. The patient themselves has to be signed up to intensive reablement for 10 to 20 days. So people have to be motivated, and they have to be physically able as well for rehab. Discharge destination is their usual place of residence, so home. And there has to be, as I said, a sort of judgment that the person is going to be able to regain function. They may not regain full function. We're not looking for, you know, kind of Lazarus-like improvements here, but there needs to be enough of an improvement that somebody, or the potential for improvement, that somebody can go home. That may be with help, or maybe completely independently, and we see both. So they have to be over 18. They need to have a discharge summary completed. We've got treatment escalation plans in place. emergency escalation plan agreed to avoid readmission to the hospital. That does sometimes happen because obviously we want to take positive risks, and occasionally somebody will deteriorate and have to go back to hospital, but as you'll see, that is a minority. And then obviously ongoing care plans completed with specialist involvement. There are some exclusions. We don't take stroke patients because there are different services for them and their rehabilitation takes longer. In this service, we're looking at 10 to 20 days. People who've had chest pain within the last 24 hours, we won't take. Anybody on intravenous therapy at the moment, we won't take. People who are homeless don't have a fixed phone simply because the problem then becomes a social one and they just get stuck in the nursing home. If people are medically unstable as well, they don't. Because we started off doing the pilot focused in Somerset, working with Somerset GPs, we don't accept anybody who's got a Dorset-based GP, but that could change. It may actually have changed already, I'm not entirely sure. So I've got data up until October actually, but we've had over 600 admissions. If you think 18 beds, people staying an average of, as you'll see in a minute, between 11 and 14 days. So the cycle through is quite quick for in care home standards. When we started, before Home First started, average length of stay was only 11.63 days, which is very good. Many services across the country doing similar things are sort of 4 to 6 weeks. So we're managing to turn people around quickly, and we believe it's because of the intense nature of the therapy that we're providing, and it's consistency 7 days a week. So I mentioned Home First, so I'm sure most of you are aware of this service, which is being developed all over the country. But the idea is to get people home as quickly as possible and to discharge, to assess, to evaluate people's ongoing needs when they're not in a hospital environment. So we are doing Home First, which is the reablement work at home in our home as well. So what we're seeing is that the people with lower level needs are going straight home with therapy input and with reablement home care. And people now coming to our service at Cookson's Court have more complex needs, and that has changed the kind of interventions that we need to do, and importantly has meant that we've had to engage more help from the GPs, because in some respects, the GPs themselves say that it's become more like a general medical ward than it was before. So, which is fine, we can manage that, but we have to make sure that we've got the right medical input when required. So the GPs have been commissioned to do extra time with us to support the greater complexity of need, but it's still less expensive than having somebody in an acute hospital with medical consultant support that they don't actually need for this part of their reablement. So you can see the effect of Home First on average length of stay. So it has increased by a couple of days, but we're still managing to come in under 14 days, which we're pretty pleased about. We've had a real age range of people. We've had people 100, 106 coming in for reablement and going home again, which is pretty cool, we think. When we first started, until before Home First, we were getting 95% of people discharged home, back to their normal place of residence, their home, with only a very small number being returned to YDH. In the early stages, when Home First started and we started getting people with more complex needs, we did end up having to send a number of people back to the hospital because they sent us people that were sort of really not really medically fit in the way that we needed them to be. But actually we've been working very closely with the hospital. They put one of their nurses, liaison nurses, to work with us on our care home floor so that they could understand better what requirements we have to meet. I'm quite often asked about governance arrangements. So from a governance perspective, it's our CQC registration, so the governance responsibility sits with us ultimately, but we have and so, we obviously are monitoring all of the normal things that you monitor, falls, infections, wounds, everything. And we have our own clinical and quality and clinical governance committee that we scrutinise all of these data and take the learning from any incidents and so on. But in addition, we have a monthly joint clinical governance meeting with Yeovil District Hospital where staff from both parties come together and we talk about any issues that have come up. Yeovil Hospital also reports incidents through their system, but they won't necessarily match all of ours because we're there 24/7 and Yeovil staff are just there sort of 8 o'clock in the morning till 8 o'clock at night. But we copy each other our incident reports and we have a very open and collaborative approach to addressing any issues. The main issues that we've had actually have been discharges without the right documentation and without the right medication, but frankly that happens across all care homes. So in this case we've got very good mechanisms and very good working relationships at all levels, at my level, at the, and at all of the levels below. So we managed to smooth over any difficulties. So we're very keen to measure outcomes, and what happens is that the therapists start conversations with people when they're in hospital to understand what outcomes they want, and they'll be different for each individual. So one person might say, I want to be able to have a shower myself. Another person might say, I want to be able to walk upstairs so I can get to the bath. Somebody else might say, I want to be able to cook my own food, so, or any combination of all of those normal activities of daily living. Maybe something like, I want to be able to walk more quickly so that I don't feel embarrassed when I'm going out with my friends to the garden centre or whatever. And then what we did when we were doing the pilot was that the therapists assessed when somebody was in hospital what home care they would have prescribed if somebody was going straight home, and then they moved them over to us at Cookson's Court, and over the period of time that they're there, so the sort of 10 to 14 days, measuring attainment of their outcome using the goal attainment scaling scores, which enable you to measure achievement of outcomes even if people's outcomes are very different. And then we assessed the scores and prescribed what sort of ongoing support people would need at the end of their stay at Cookson's Court. And then that sort of enabled us to look at the costs overall, and I'll come back to that later. But what you can see from these data are that the vast majority of people, so the blue bars are people achieving their outcomes, the green ones overachieving their outcomes, and the red ones underachieving. So if I move to the next slide, which shows the same data in pie chart form, you can see that 91% of people were achieving or overachieving their outcomes, and a small proportion underachieving. Is that right? That's not quite right, is it? 69% achieving or overachieving, and no, that is right. It's the 9% who. I think I've got these. I think the colours are wrong. I'm sorry about that. The green one is actually the underachieving, and the red and the blue are the achieving and overachieving. Sorry about that. So it's 91% altogether that are achieving or overachieving, which you can see from the previous graph. Sorry about that. So in terms of costs, so there's an opportunity cost associated with the time it takes for patients to be assessed and a long-term care plan put in place. Yeovil estimated that on average there's a delay of 20 to 25 days between a patient being judged medically fit and having their long-term plan of care confirmed and put in place. So imagine if we could truncate that period. That would make quite a substantial difference. So they've been tracking cost of plan of care delays. For some reason, actually, that increased when Home First started. I'm not entirely sure why, but you can see that it ranges from sort of £10,000 to £30,000, for the delays, which is really quite a lot, and we really do need to try and get that down. And it isn't as simple as you think, because obviously people's social circumstances, discussions about funding, all kinds of things can get in the way, having equipment put in homes and so on. But according to the Department of Health data, and I am aware that this varies substantially across the country, but just using DH data, average cost of bed in an acute hospital, £400 a night, £2,800 a week. Certainly in Somerset it costs about £2,000 per person per week to keep them in a community hospital bed, so £285 a night. In this service, our fee rate for a week for somebody is £825. So the nursing home costs are substantially lower than in hospital. And importantly, it's a better environment. In the hospital, people have to share wards, sort of 8 beds to a ward. There's no privacy. They have to sort of get out of their bed, walk down the corridor to sort of shared toilets, whereas in our nursing home, people have ensuite bathrooms in their rooms. And the most common comment is just how much quieter it is when they move from being in a busy acute hospital, which frankly are not designed for long stays. They never were. They're there for short-term acute episodes. And because the therapists are there the whole time, there is a kind of confidence that comes. When we do reablement work in people's own homes, sometimes people will sit in their armchairs waiting for the carers to turn up 3 or 4 times a day, whereas here, because they know that people are around all the time, they're more likely to try things, to get out of their chairs, to try walking, to try making their own cups of coffee, to try having showers and so on. So we have a hypothesis that people rehabilitate faster in this way, but we haven't got hard data to confirm that, because trying to get similar data in the home care environment is much more difficult. Well, it isn't difficult, it's just not being done. So, that is a key piece of work that needs to happen. But what we've seen is that 42% of people required a reduction in their predicted care packages upon discharge from Cookstone's Court. And so we calculated that in the first year of doing this collaboration with just our 18 beds in one nursing home, we saved the local authority 1.6 million per annum in downstream home care costs. Yeovil, from their side, have managed to, it protects their elective surgery, stops them from having to cancel surgery. So they believe they've protected income of around 1.9 million. We've had some really great feedback from the people who've used this service. Some of it's here. The world is a better place because of people like you. Wonderful staff, highly efficient, compassionate and caring. No praise is high enough. Total credit to the service. Dad returned home with renewed confidence. And that's a really key feature. People really lose their confidence when they're in hospital. It's not because it's nothing to do with the hospital, but just the fact that perhaps they've had a fall or something, they were living independently at home, and suddenly they find themselves quite vulnerable and worried that they might not be able to manage. And so a large part of the work is just re-instilling that confidence in them, and having people around helps with that. And we've also seen too the effect of just moving somebody out of hospital, because there's a psychological factor there that when you're in hospital somehow or other you feel ill, and just the fact of being moved out can suddenly give people renewed energy and vigour. And we've had a number of people who've been discharged on end of life care allegedly, but like 3 days later they're dancing around playing dominoes. So the environment is really, really key. And just a huge amount of gratitude. Cannot praise therapy staff highly enough. Staff were always willing. Thank you for everything. There are no words to express my gratitude. Thank you with all my heart. I've been born again. So, you know, that makes our staff feel great, that they can actually see people improving and being able to go home and have independent lives. And as I mentioned, you know, our oldest customer so far has been a 100-year-old. Harry, here you can see him walking around the garden. A little while later, unfortunately, he fell over again at home and broke his other hip and ended up back in Yeovil Hospital. And, you know, we do have to accept that with people of advanced old age and frailty, you know, there is a limit to what you can do to totally make them immune from this kind of thing happening. But at least it gave him some extra time at home and that sense that he could recover, and we'll carry on doing the same. So we've got quite a number of case studies, but this is just one to give you an idea. So there was a 73-year-old lady who was admitted to Yeovil Hospital. She fell from some steps. She was unable to bear weight. She had very sort of slow progress in mobility and function. She had to have 2 people to help her move. She wasn't able to complete personal care activities. She felt that she'd been kind of left in a bay in a busy hospital and no one paid attention to her, and it's just because the hospital is really busy and they just don't have the time to really put that attention into one person. And also, as I mentioned earlier, the environment isn't really that suitable. There isn't really anywhere where people in the hospital can go and make a cup of tea or have a shower in privacy or whatever. The orthopaedic team in the hospital felt it was too unrealistic to mobilise this lady without a frame or complete steps. Therefore, they were planning to send her home with double up personal care. This shows you, you know, how difficult it is to assess people in hospital, and B, how generally risk averse they are in hospitals. Many cases, actually, it's home carers who have the best idea of what people will be capable of because they see it all the time. In some cases, they may know what people's home environment is like. But she was admitted to Cookson's Court in June 2016, and within 3 days in the first week, she was independent with using the bathroom, independent using the shower, independent with one person helping her. Within 4 days, she was able to carry a hot drink while moving, and she was independent outside with a stick, able to complete a full flight of stairs. And then she was back home sort of 5 days later with no plan of care. And she really was amazed. She didn't think that she'd be able to do that for months. So, as I said, a lot of the work is instilling that belief, that confidence that people can get themselves back to normal, can regain function. With some people it takes longer than others, but with that determination and practice, an awful lot of function can be restored. What we've learnt very much is that you don't have to have a complex reorganisation or even a complex rearrangement of budgets, because we managed to make this happen in a slightly rebellious fashion, we do admit, by the strength of our relationships and just by being determined to have a go. In fact, now the collaboration is funded fully by the local authority, which is great. And what I would also say is that the relationships that we've built with our colleagues in health have enabled us to extend out to doing more collaboration in other care homes in different ways. So we've got more health input to the care homes. We've managed to convince the GPs that they should visit the care homes. They should divide up the care homes in Yeovil, for example, between the GP practices, because we were experiencing some care homes having virtually no GP input, some having visits from 8 GPs, and research evidence across the country shows that if you can have regular input weekly from GPs to a care home, you can actually reduce admissions to hospital by up to 40%. So that's been really positive. The hospital has understood much better what's involved with giving care and the kind of requirements that we have to fulfil for our governance and our CQC registration. And so all round it's been a very, very positive experience, and one that we very much look forward to building on as we go forward. So that is where I was going to stop, and I guess we can take questions and discussion.
Yeah, before we start the discussion with Jane around some of the questions you've asked, I just want to give you a couple more minutes to get in any other questions before we start. So I'm just going to pause for a second if people want to type in any further questions. That we've already heard to Jane. Jane, we had a couple of questions from Melanie. First one, quite simple. Does the intermediate care programme include people with dementia?
Yes.
Lovely. Also, she asked, how quickly can people start on the programme? So, how easy is it to achieve kind of a start within the first couple of days of referral? What's the time scale?
The whole thing is actually very smoothly managed because as I said, the therapists manage the flow, and the only limiting factor is availability of beds. So they will, as long as they can keep moving people out at the back end, which we are doing successfully from having length of stay of sort of 2 weeks, then they can come in the front end, and it's just then a case of making sure that the paperwork is there, but it's all quite quick once those decisions have been made.
And I suppose linked to that question about the 2 week length of stay, a colleague Lance asked the question that 2 weeks is clearly a very impressive figure. What number of hours though go into that 2 week period? If it was a similar number of hours over a longer period, so a less intensive re-ablement, do you think there would be similarly good outcomes, or is that intensive nature of it part of the success of it?
Well, the short answer is we haven't got the data on that,
right.
But we believe that the intensive nature of it does speed things up, because in the home care situation, we know that it can take much longer, because then you've only got a few visits a day, and you don't necessarily get that. You can make it even more personalised, I'd say, in this environment, because some people will need more support than others. For some people it will just be more about confidence. Actually, some of it depends a little bit too about because people's relatives will come and visit, and sometimes they will also encourage and support and help. So I think the amount of hours will vary quite substantially with individual people. So Harry, for example, he took longer than 2 weeks, but he was 100 and quite frail and had broken his hip. So you sort of expect that. But somebody who's younger and very determined will take less time. So it very much varies.
Okay. And another question again from Lance, actually, could it work without nursing, i.e. in a standard residential care home, or is having nursing key to? Well,
it very much depends on your admission criteria. As I said, especially now, we're receiving people with quite complex care needs, and they definitely need nursing. But you could construct something with lower needs, but then the question would be, is it better to send people home or have them in a care home? I'd say that if somebody's home wasn't, you know, suitable from an environmental perspective, it would be better to move them from hospital into a residential home to do something, whilst it, you know, modifications were being made or something, rather than leaving somebody stuck in hospital. Because in a residential care home, at least speaking for ourselves, you know, our environments are just much more suitable for people. They're more like home, and psychologically they get into a better place.
Yeah, so that point you made about, you know, you have your own toilet and you're not, and you have the confidence. And so how much of the work is done by OTs and physios with those qualifications as opposed to care assistants?
Well, the OTs and physios are, you know, the sort of like the consultants, if you like, and they've got a team of rehab workers around them, and then also our care workers too. And actually, if you go onto the floor, it's actually very, apart from a difference in uniform, well, we don't wear uniform, but Yeovil do. That's the only difference that you can really tell. So they very much sort of moulded as a team, because they've got a joint purpose. You know, they share the same values. They just want to do the right thing for the people. Help them to regain independence and go home. So it's very, I'd say that we've seen the benefits of the teams working together because they've each learned things from each other. We're very keen that this, you know, that any care home is not seen as a hospital with armchairs. So that there's a bit of a cultural adjustment, if you like, you know, from it being a very sort of clinical environment to being somebody's home. And I think that's what probably the hospital staff have learnt or gained, and you know, we've obviously learnt a lot from the OTs and physios about the kind of things that can be done. But they will teach and set up the plans, and then everybody else will make sure that those plans happen. And the OTs and the physios do the assessments as well.
Okay. Now, obviously, any successful scheme like this, it depends on the kind of the wider network. So how do the GPs fit into this? We've had a couple of questions about GPs. Are they still getting funded for their extra support, and how do you link into the person's individual GP?
So obviously care homes have access to GPs because people are, you know, considered to be in the community when they're in a care home. We did originally have a number of different GP practices supporting this care home. Now we've only got one because we wanted that consistency. It doesn't mean that residents have to register with them, by the way, but what tends to happen over time is that they tend to just use that GP because they're there and it's easier. Initially, we didn't really have that much call on the GPs, just as in a normal, you know, nursing home situation. But as I said, when the Home First service started and we started to receive more complex patients, we needed the GPs more, and that part of it didn't go too well because there wasn't a discussion with the GPs at the beginning of when Home First started. They weren't involved in the in fact neither were we really in the discussions about the change in admission criteria, so they got a bit grumpy, understandably, because they can't just work without being paid. But we did, you know, after some conversations, they are now being funded, and that funding is continuing for them to give enhanced input. But it's still, if you look at overall costs, you know, cheaper than somebody being in an acute hospital.
Absolutely. And another important part of the network is kind of the supply of equipment and adaptations. How do you link into, this is a question from a colleague called Jane, how do you link into adaptations for when people discharge back home?
That's obviously the occupational therapists who lead on that, and so right from the word go, they are working on making sure that everything is set up for people to be discharged. So when people are still in hospital even, they will be starting to get information from the families about things like, you know, chair height, bed height, position of furniture in the rooms, and we will make adjustments in the care home where we can to make it as like somebody's home as possible. But while they're in our service, all of those equipment things are being done, and that's also an important part of it. So there are no delays from moving. You know, that's part of the reason why we can keep the length of stay quite tight, because those things are happening behind the scenes.
Earlier on, Emma asked a question about how this fits into the discharge to assess model.
So this is part of the whole discharge to assess scheme in Somerset. So we've got 3 pathways, pathway 1, 2, 3, which is common with many other areas. So pathway 1 is people going straight from hospital home. This is pathway 2, and then pathway 3 is people going to care homes but who they're more advanced dementias usually, and people there is less certainty about what they're going to need in the long run, whether they're going to need long-term residential care or whether they can go home with support. We're actually not involved in pathway 3, but other providers are in Somerset. So the whole thing is managed. The local authority is sort of overseeing the whole thing. We're collecting data on all bits of it, and there are sort of meetings, county-wide meetings to look at what's happening in the different pathways, and sort of trying to learn from things that haven't worked out quite well. So especially when we first started Home First, they were sending people home who really shouldn't have, they should have been in pathway 2 rather than pathway 1 sort of thing. But by getting that feedback, we've been able to make adjustments and kind of learn. And we've always got the option of moving people from one pathway to another, anyway. So because we're all working in a collaborative way.
There was a really interesting question from Jacqueline about hearts and minds and how you go about convincing the person and their family that this is the right form of care. I guess there might be a sense that hospital is the safest place for someone to be, and are you meeting any resistance with that, or are people more than willing to embrace this kind of approach?
No resistance. The therapists have those conversations with people. Obviously families, if they want, can come and visit in advance, but honestly, as soon as they see the environment, they're like, whoa, yes, well, come here, please. Because it's only sort of a couple of years old now, and as I said, people have all got their own ensuite rooms. They've got loads of space where they can walk and do stuff. There's all kinds of activities organised as well, which you don't get in hospital. So it's a bit of a no-brainer, really.
And just on the activities, was that an alpaca or a llama? How are they permanent residents, or are they?
That was an alpaca. We have quite regular visits from them, actually, and in fact we had, I think it was BBC or ITV in the home filming one day, and we had birds of prey in there, so like these owls flying around as well. But it's not, it's not just animals, it's all kinds of things. So, and one of the great things about this is that obviously there are some permanent residents in this care home, so there are 2 other floors, and people mix all between the floors, and so the people who live there permanently have got, actually they've got a little business going downstairs, because they've discovered that they can get plates from charity shops, and they sort of get someone to drill a hole through them, and they're making all these cake stands and then selling them, so they've got this little production line going, and so they can go and join in with that. Or some of the ladies have a knit and natter thing that they do, and we also offer outings to garden centres, and if people are ready for that, then there's no reason why they can't do that kind of thing as well. So it's trying to be more normal, getting back to more normal life, really.
There's also been a question about the relationship between the different organisations involved, and it relying to some extent on goodwill. Now, and the point, I suppose, that if that's lacking, then you do end up with a postcode lottery, because yes, if those relationships aren't there, then these sorts of things don't develop. I mean, how important has that relationship been between you and Yeovil, and if it's not there, what tips would you give on how to kind of build those sorts of relationships that allow for this sort of flexible working?
Well, obviously, when we started, it was basically, the will of myself and the CEO of Yeovil Hospital wanting to do this. But then I guess that kind of trickles down. But as I mentioned, you need to build those relationships at all levels. It's no good having it at the top or just the bottom, because things do arise. We do quite often have, things that create conflict, like in any human interaction, but because we've got those relationships, it's much easier to pick up the phone, or to go and see. We've had regular meetings set up as well, And of course, because the hospital staff work on our floor, I think that is really key to it as well.
Yeah.
Because in other collaborations across the country, the intermediate care, they'll just be moved from the hospital to the care home, and then it's 100% care home.
Yeah.
And there's no input, and then you can get an us and them thing. I also think, as I said, that rotating the therapy and rehab teams through the hospital. I think what we'd really like to do as well, so our staff participate in the discharge meetings too, so what we'd really like to do is get a bit more secondments in both directions. So we've had a liaison nurse from Yeovil working on our nursing home floor, sort of, on a permanent basis for a period of time, and that was quite an eye-opener to her. She said, for example, she didn't realise how much detail we have to put in the care plans. She didn't realise that we don't just keep stocks of medication. It's like we don't have a pharmacy, funnily enough. So when they send people over without the right medication, that means we have to contact the GPs, and then that makes the GPs cross. So actually, when everybody understands what everybody, the parameters that everyone's working in, it kind of makes it easier. And they say, yes, so we really cannot, we can't assume that there is spare, even paracetamol, it has to all come. And if somebody does end up on our doorstep without a discharge plan, we'll be straight on the phone saying, please send one over PDQ. So, but it takes time, and and it isn't a quick thing, but like I say, there is a real willingness generally, to work with care homes, and we've shifted the conversation as well, because nationally I've noticed there is a bit of we're the NHS and we're here to show you all how to do your jobs properly. I think what we're seeing is a building of respect for an understanding for what goes on in care homes. So that conversation has changed. Yes. And which is very positive. So I think the more of that, the better, really. And we've also had some of the consultants actually come out to the care homes too, to work with our staff on people with particular conditions, in helping us with the treatment escalation plans and so on. So for example, consultant who's got specialism in neurological conditions, explaining to staff what might happen with somebody with Parkinson's. So if that happens, you don't need to worry too much, because that's normal. If that happens, then you do. And then, because we're trying to sort of cut down on the number of times, for example, out of hours is called, and people ending up in hospital unnecessarily, because although people think hospital is safe, actually, for people of a particular, people with dementia and frailty, it's actually many times quite harmful, because once they're in there, it's devil's own job to get them out again, and then they lose function.
So Jacqueline, I think that was you that asked that question. Perhaps get your commissioners and your funders to listen to the recording of this, and they can hear Jane's tips for how to create a sort of more constructive environment. A couple of other questions, from Karen, about the average weekly cost.
Well, like I said, it's £825 a week per person.
And that was compared to about 2,000 for a hospital.
And if you think, that's £117 a night or something, is less than the cost of a night in a Premier Inn, where you have no 24/7 care, you don't even get your meals. You're lucky if you can find someone to grunt at you on reception. So it is, good value. Of course, the problem is, that until the whole funding mechanisms change, that the hospitals are paid for people in beds, and until there's a way of shifting funding around the system, the NHS is still being paid for, and then this is kind of being paid for on top. The justification is that we're cutting costs downstream to the local authority. But the local authority, quite understandably, is saying, well, hang on a minute, we're paying, but actually we're sort of saving Yeovil money, or we're protecting income. So really, in an ideal world, it would be jointly funded by the CCG and the local authority, in my opinion, preferably with some joint budget. That's how we really need to think.
Absolutely. That problem of one organisation saving another organisation money and therefore being less willing to engage.
Yeah.
I think it's Claire asked about service level agreements so that people can access other health services such as diabetes care or speech and language therapy.
That's no different from normal in a care home, so we can access all that stuff anyway.
Yeah.
So yes, and there are
even for the people that are just likely to be there for a week or two.
Yes, if they need it, and diabetic nurses, tissue viability specialists, anybody. So. And
I was wondering this, and Jacqueline's asked it. Yes, do some people enjoy it so much that actually, whilst they could go home, they've now decided that all the activities, the relationships mean that actually they don't want to?
Well, that happens. It does happen, but actually most of the time people are quite keen to get back home. In a very small number of cases, we did have a lady who she'd lived independently at home until she was 96, I think. And then one weekend she had a fall at home, and her daughter, who lives locally, and husband were away, and they were phoning and didn't get a reply, and they had to, in the end, get someone to go and break down the door and all of that. That experience was quite frightening for all of them. And so she decided, I'm 96, maybe it's about time that could happen again. I don't want my daughter not to feel that she can go away. Occasionally that kind of thing happens, but in the you can see, the vast majority of people go home. Between 91 and 95% of people go home.
Yeah. And if it's a positive choice to stay, then it's a positive choice. We're coming to the end of our session. Melanie, I can see you're typing, so there we go. We'll take Melanie's question and then we'll wrap it up. So, do you take referrals from the community as well, or is it? Well,
in this particular service, probably not. Although, as I said, the discharge, the 3 discharge to assess pathways are all kind of managed, and I think if it was felt that somebody had been discharged on pathway 1 and it was really the wrong thing to do, we would potentially be able to take them in if they kind of fell in the catchment of Yeovil. It just involves some conversations, but generally speaking, this is a pathway from the hospital to here and then home.
Okay. Well, that takes us more or less neatly to 1 o'clock. So thank you very much, everyone. Let's say a recording of this and a transcript of the sort of chat will appear on SCIE's website at some point next week. So keep an eye out for that, and we can notify people, I believe, of when that's up. So yes, await the notification of that, and you can share this with colleagues or remind yourself of some of the points. So that just leads me to thank Jane very much for the presentation. I think a lot of really interesting practical ideas. I really like the sort of the feature of the rotation of staff between the home and hospital, so that that there's that investment in people's ongoing futures. So thanks very much, everyone. I hope you found that useful and enjoyable, and enjoy the rest of your day. Thank you very much.